Hello and welcome. My name is Rebecca Andrade, and I'm the Educational Programs Manager here at the Kansas Health Institute, and I would like to welcome you to the third session of our Bring It Learning series, Understanding OBBBA, or HR1, and its impacts on Medicaid and CHIP in Kansas. The Bring It series is made up of 5 one-hour educational sessions about health policy topics related to issues that may be considered by the Kansas legislature this session. These sessions are an opportunity to bring your lunch, your questions, and perspectives to these important topics. So, a little bit about who we are. KHI, or the Kansas Health Institute, is a nonprofit, nonpartisan educational organization based in Topeka. We were established in 1995 with a multi-year grant from the Kansas Health Foundation, and we are guided by the vision that Kansas will become the healthiest place to live through evidence-based and innovative strategies, policies, and practices. We work towards this vision by providing nonpartisan information, convening crucial conversations, and facilitating learning that leads to meaningful change. If you visit our website or stop by our building, you'll see that our work involves research, evaluation, technical assistance, and policy analysis, as well as podcasts, blogs, and gatherings like today's event. And now, it is my pleasure to introduce my colleague, Sheena Schmidt. Sheena is a Senior Analyst and Strategy Team Leader here at KHI and will be facilitating today's session. Over to you, Sheena.
Thank you, Rebecca, and welcome everyone. We have a lot of great information to share with you today. So first of all, we're going to talk through key impacts on Medicaid and CHIP in Kansas as it relates to HR1 or OBBBA. And then we're going to dive deep into some specific impacts that we're anticipating for Kansas through having a conversation with Audrey Dunkel, who's here with us today. She's the Vice President of Medicaid and Legal Affairs at the Kansas Hospital Association. Thank you so much for joining us. So we'll go ahead and get right to it. We would also like to share a resource guide with you. It will be available for you in the chat. It shares a little bit more about the event, and you can access resources that help guide today's discussion and provide more details into the topics that we're going to be talking about today. And we do want to hear from you. You can be anywhere today. What brings you to today's session? If you'll go ahead and enter your answers into the comment section in the chat, that would be great. So we'll give a few seconds for everyone to share what brings them to have their lunch with us today. Want to learn more information about OBBBA, just interesting to hearing about the changes, ongoing learning, oh, guiding others to resources. We were promised cookies, maybe next time. All right. Thank you so much. We're really grateful that you chose to spend the hour of your day with us, and we hope that it will be informative. We would like to acknowledge staff members at KHI who have supported this work. You can see their names and information on the screen. Carrie Breffett, our president and CEO, Shelby Rowell, who helped develop today's session, and you'll hear from a little bit later. Rebecca, of course, who you just heard from, and Cynthia, who helped with the materials that we're going to be referencing, the brief and the timeline associated with impacts to Medicaid and CHIP in Kansas. All right, well, we can get right into it. So a few quick facts about Medicaid or KanCare in Kansas. It is the third largest domestic program in the federal budget behind only Medicare and Social Security. In FY26, the federal Medicaid assistance percentage in Kansas, or the match rate, is 60.67%, meaning that for every dollar that Kansas spends on Medicaid, the federal government contributes about $1.61. And the match rate for the Children's Health Insurance Program, or CHIP, is a little bit higher at 72.47% in Kansas for 2026. And Medicaid is administered by the Kansas Department of Health and Environment and the Kansas Department for Aging and Disability Services. Kansas contracts with managed care organizations that provide health coverage to Medicaid beneficiaries across the state. Thinking about who's covered within the Medicaid program, Parents with low incomes and their children, that includes pregnant women, parents or caretakers, and infants and children, including children in foster care. Older adults with low income and those with disabilities. So you'll see the various programs that are involved that are included in the Medicaid program for those individuals there. And then other Medicaid populations include eligible individuals with certain health conditions like breast and cervical cancer, tuberculosis, or AIDS. And it is important to note that adults without children in Kansas do not qualify for Medicaid, even if their income is zero, as Kansas has not expanded Medicaid as of yet. So now we'll transition on getting into the impacts of OBBA on Medicaid and CHIP in Kansas. There are a few key findings that we want to highlight to start off our conversation. First, it limits Medicaid financing tools. So it limits the state's ability to fund its share of the Medicaid program or the cost of the Medicaid program. So there's new federal restrictions on provider taxes and state-directed payments. And we will get into that in a lot more detail later on in today's session. It also includes enrollment administrative changes. That's related to shortened retroactive coverage windows, stricter eligibility requirements, and verification and administrative requirements for agencies, which I'll also talk about in a little bit. And lastly, it reduces the incentives for Medicaid expansion. And so I'll go ahead and talk through that. We're going to walk you through a timeline of these key provisions when they go to effect in a little bit more detail about each one. All right. So thinking about all of the impacts, we've selected a few key provisions that will impact, or Medicaid-related provisions that will impact Kansas over time. This doesn't include an exhaustive list of all of the provisions that are in OBBA, including, I'm sure you've heard about changes to SNAP and other programs. This today's session is really focused on health policy provisions. But in July 2025, you can see OBBA was enacted. There were some few initial things that went into effect right away, including establishing stricter criteria for provider taxes. So to qualify for federal matching funds, provider taxes must meet several conditions, including being broad-based, uniform, and generally redistributive, meaning that the tax burden and benefits of provider taxes should be spread across providers, not benefit one type of provider over the other. So what OBBA did was it tightened the definition of generally redistributive, which limits states' ability to design taxes that may disproportionately benefit the providers that are paying those taxes. So the stricter rules apply to both new waivers and existing waivers when they come up for renewal, which could reduce states' flexibility in financing Medicaid. It is important to note, though, that generally redistributive that was in place before OBBA, but this is just kind of tweaking the definition to make it a little bit more strict. In addition, CMS rules regarding long-term care staffing and eligibility rules are delayed until 2034. It delays implementation of those two rules that would require higher staffing levels in nursing homes and more reporting. And then the other rule related to eligibility would simplify Medicaid enrollment by reducing paperwork and automating some eligibility checks. So those won't go into effect for several years now. And I'm sure we did our another session specifically on the Rural Health Transformation Program, but noting it here in December of 2025, that's when states received award notifications for this program, and the funding period goes from 26 to 2030. So that's something that CMS, or the Centers for Medicaid or Medicare and Medicaid Services, are administering, and so that will be something that will definitely impact rural health in Kansas and Medicaid beneficiaries across the state as well in those rural communities. Medicaid expansion. So there were several provisions related to expansion, both for states that haven't expanded Medicaid and states that have expanded Medicaid. but as of January 2026, OBBBA removed the enhanced match rate incentive that had encouraged states to expand Medicaid by offering a temporary bonus, like a signing bonus for the states that hadn't yet expanded Medicaid. If they choose to do so, they were able to get a temporary bump for 2 years. So without this incentive, states like Kansas that may be considering expansion or still discussing that, they faced reduced financial motivation to expand the program. Um, so according to our last analysis, we estimated that Kansas would have received around $542 million for choosing to expand Medicaid with that incentive. So it would have covered approximately 9 years of net state expansion costs, and without that incentive, that would go away. So it would definitely make it less financially viable without it, but there's still analysis to be done to see in the new environment what expansion might look like going forward. All right. So in January 2027, enrollment procedure updates and other updates will go into effect. Um, and the main one that may impact Kansas is that there's changes to retroactive coverage for those that apply to Medicaid. Typically, um, the period in which Medicaid enrollees can retroactively enroll in Medicaid after a qualifying event is shortened. For non-expansion states, it's reduced from 90 days to 60 days. So that does apply to Kansas. States also have to now conduct, at that time, quarterly deceased checks and disenroll beneficiaries and providers that are found to be deceased. And then also a couple of other administrative changes will go into effect. HHS will be required to create a system to detect and prevent people from being enrolled in Medicaid in more than one state. And so states have to start submitting social security numbers, verifying addresses, and fixing the situation if it's deemed to duplicate enrollment is found. So some of these changes may um, result in, specifically around the retroactive coverage requirement could lead to barriers to enrollment, including coverage disruptions, particularly for individuals with unstable incomes, those in long-term care facilities, or applications that may require that are pending for a longer period of time. So maybe more complex cases may face some challenges there with that shortened retroactive coverage provision. And then also the state would have to have additional administrative burdens due to those increased requirements that I just mentioned as well. There's also a budget neutral requirement for Medicaid waivers. Any waivers are required to be budget neutral by the CMS chief actuary. They were required to be budget neutral before, but it looks like just like the um, provider tax definition is just making that a little bit tighter. All right. So in January 2028, that's when we'll see the changes to state-directed payments. Those rate increases decreases will start for grandfathered payments, which applies to Kansas, and those decreases will happen through 2038. And I won't spend a lot of time on it here because that's another area that we're going to dig a little deeper in the second half of the session. You'll learn more than you ever wanted to know about that. Just kidding. And then lastly, in July 2028, there's a new 1915C HCBS waiver option that will go into effect. So home and community-based services waiver option will let states cover HCBS for people who meet state-defined criteria rather than the stricter federal institutional level of care criteria. So states can have more leeway, or I guess more ability to determine what that is. Um, the only criteria is that it doesn't increase wait times. So federal funds will support implementation, um, but many states, including Kansas, may face some barriers with this due to the existing wait list they have. All right. And so you can see the select provisions all together there. I will go ahead and reference in your resource guide, there's a link to a full timeline of other these provisions and more, in addition to a brief that goes into more detail about all of these provisions, including the state's ability to fund its share of the Medicaid costs and what it means for Medicaid expansion going forward. So it's there in the chat and you can click on it to learn more. Right. So now I wanted to go ahead and direct your attention, now that you've learned about a few of the different provisions in OBBA, we have a poll for you. So we'll go ahead and start that poll. We just want to hear, what do you want to learn more about? So which of the following OBBA Medicaid related provisions are you most interested in learning about regarding impacts to Kansas? Go ahead and take that poll. We'll see what the audience is interested in. Right. It looks like most of you are interested in digging in a little deeper to the eligibility and enrollment changes, in addition to the Rural Health Transformation Program funding and opportunities, um, and the Medicaid waiver changes. Very good. So that'll help us kind of understand what more content and research that we might want to do around these specific provisions and how they'll impact Kansas. Thank you so much. All right. Now we're going to get into a little bit more detail about the state financing tools and how the state funds its share of Medicaid costs. At the beginning of the presentation, I shared about this is the match rate. And so the federal government provides like $1.62 for every dollar that Kansas puts in. And so part of the way that the state funds their share of their Medicaid costs is through provider taxes. So what are they used for? They're used to finance a portion of the non-federal share of state Medicaid costs, and they generate state revenue to pay expenses that draw down federal matching funds. And they help support enhanced reimbursement rates and maintain access to care. So hospitals will pay provider taxes, and then in return, the federal government provides match rates back, and those dollars are used to provide care and additional enhancements for providers to provide services like in rural areas or improve access to care, for instance. It's a widely used tool. 49 states and DC uh, use them. They used at least one provider tax in 2025. So Kansas provider taxes support Medicaid payments to hospitals, physician, nursing facilities, and home health providers across Kansas. An CMS approved rate between 5 and 6%. Recently in Kansas, they made this change. So it's the maximum allowed under current federal law. And this was recently extended to critical access hospitals and rural emergency hospitals in 2025. And that has been approved, but they're still pending approval to expend those funds. Other facility types, including nursing facilities and continuing care retirement communities and small facilities, also pay provider taxes. And how did OBBA make changes to provider taxes? So what it did was it froze existing provider tax rates through September 2028 and prohibited new provider taxes. It requires some states, specifically expansion states, to phase down their provider tax rates to 3.5% by 2032. But since Kansas is a non-expansion state, it would likely retain its current provider tax structure, that between 5 and 6% under the grandfathering provisions in OBBBA. And we'll kind of dive into a little bit about how that came about with Audrey here in a minute. The other way that Medicaid financing tools work is through state-directed payments, and sometimes provider taxes provide money for state-directed payments in other sources. But what are they? Um, they're used to supplement base Medicaid provider rates and maintain access to care. It allows states to require managed care organizations to pay enhanced rates to certain providers to incentivize that access to care, maybe in rural areas or for maternal care, for instance. And it's funded through provider taxes or other non-federal funds, as I mentioned, which draw down federal matching funds. And Kansas has used STPs to enhance payments for inpatient and outpatient care in hospitals, academic medical center, so that equals the University of Kansas Health System, and for Children's Mercy Hospital. What did OBBBA do to state-directed payments? It capped state-directed payments at 110% of Medicare rates in non-expansion states, and this includes Kansas, and 100% of Medicare rates in expansion states. So what potential impacts could that have? Beginning in January 1st of 2028, any state-directed payments exceeding 110% of Medicare must be reduced. Payments above the cap reduced by 10 percentage points annually, including for the grandfathered payments. So Kansas will have to do this as well. In Kansas, the rates are projected to exceed 200% of Medicare rates by 2028. So once those phase downs start happening, hospitals are likely to experience phase reductions in SDP related revenue. And by 2038, these payments must be fully phased down to the 110% of Medicare rates. So Kansas may need to identify alternative funding sources or consider adjusting other Medicaid payment strategies in order to, be financially stable. So now that we've talked a little bit about what are provider taxes, what are state-directed payments, it is technical, I do understand. So we have a subject matter expert joining us today to break it down for you all. So thank you so much to Audrey Dunkel. Welcome to the conversation, Audrey.
Thanks for having me.
Yeah. Well, we're really glad that you're here to help explain how these changes to state-directed payments and, to some extent, provider taxes will impact Kansas. So I will go ahead and jump into a couple of questions, and then we will have time to take some questions from the audience as well. Um, so I think first off, just start a little broad. Tell us about state-directed payments and provider taxes. What are they used for? How does it impact access to care for Kansans?
Okay. So first of all, and I think it causes some confusion, but probably easiest to talk about provider taxes in Kansas. At the State House, they call it the provider assessment because they didn't want to call it a provider tax. It's also called the Healthcare Access Improvement Program, or the HCAP. So you'll hear me use that interchangeably. So I apologize for the confusion, but I've called it everything over the 20 years I've worked with this program. So the provider taxes or assessments are basically how you generate the revenue. And you go to CMS, you get approval for the tax. You can't tax prior to HR1 or OBBBA. You couldn't tax above 6% of revenue. And so this is making a little bit of a change to that. SDPs, those state-directed payments, are just a way to expend the dollars. For example, our program was approved by the 2004 legislature. And at the time, the dollars were expended by enhancing the base rates for Medicaid. And so at the time, that enhancement rate was an additional 25% on top of the Medicaid program. However, our program started to exceed the funding. I think once we went to managed care, we lost a lot of transparency in the program because in a state-directed payment, it's very clear exactly who receives the money, how it's calculated, the timing, easy to track. But when it's part of the managed care payments, it gets bundled into basically the per member per month rate that managed care gets paid. And so when we were going back as an organization and saying, wait, how is this money being spent? In fact, we couldn't look into that because that was considered proprietary information because it was part of the managed care organization's rates. So state-directed payments truly are the most transparent way to expend these dollars for everybody. Again, the methodology is, of course, public on the CMS website. Now, when we talk about provider taxes, sometimes people get really uncomfortable with the idea of a provider tax, but it's not any different than the kind of things like motor fuel tax, vehicle registration, other fees that are charged and then used instead of state general fund to match federal highway dollars or sorry, I had to go look for these. If you think about wildlife and parks, hunting and fishing licenses and fees like that, those are used as the state match for federal dollars. So if you think about it that way, I think it becomes looks more typical to what we do across the state to match federal dollars with non-state funds to give us state funds to spend elsewhere.
Thanks so much. That's really helpful. I know Kansas has made some changes to the structure of their state-directed payments and recently. So there were some increases in the state-directed payments. So can you tell us about those recent actions by the Kansas legislature, how that came about, why there was a need to do so, and then when OBBBA passed, like how was Kansas a part of the conversation as that legislation was moving through the budget reconciliation process in Kansas? And, given those recent changes at the state level, like kind of just talk us through that.
Okay. Well, in 24, or the 24 legislature had through a budget proviso said, hey, you can increase your provider tax on the non-critical access, non-rural emergency hospitals to 6% because critical access hospitals and rural emergency hospitals were not taxed. In 25, then they put that into statute instead of budget proviso. And in addition, added the critical access and rural emergency hospitals to the taxing scheme if their revenue was above a certain threshold, because we know for critical access and rural emergency hospitals, they're running on a very thin margin. And for cash flow purposes, we had worked with our hospitals to determine what the appropriate threshold would be and then took that to the legislature. Why is that important? I think you see hospitals continue to struggle with increased costs that are not being met either by Medicaid, because any cost adjustment that's done in our Medicaid program is generally budget neutral, unless there's additional funding added to that. Sometimes that has to be significant. Two, I think as we look at the Medicare program, it pays already less than the cost of care, as does Medicaid, because Medicaid pays less than Medicare as their base rates. And that means that for hospitals that had a lot of Medicaid and a lot of Medicare, and we're an aging state, so there's a lot of Medicare, they're getting paid less than the cost of care, and that has to be made up somewhere, generally through private pay rates, but everything is not keeping up with the actual cost of care. And so for hospitals, the best way for them to basically address this issue is one, go to the state and ask for additional state general fund. And two, what we truly have control over is to say we're okay being taxed more so that we can generate more dollars within a program that is really paying us less than the cost of care to start to kind of fill those gaps. and reduce that pressure on their budgets. So the legislature approved that in April of 2025. And then we got OBBBA in June. And so our legislature had made their good faith effort to make all the changes before any of the discussion with OBBBA and the grandfathering and everything else. So that really did cause us a challenge. On the House side, Representatives Mann and Schmidt, even though they weren't serving on any of the committees that crafted HR1 or OBBBA, whichever one you want to call it, they did raise a number of concerns with Speaker Johnson and congressional leadership about what was going to happen to specifically the rural emergency hospital and critical access hospital change. And so they really worked to influence a version from the House that limited the impact on Kansas hospitals and providers. In the Senate, then, there were significant changes made to HR1, but Senator Moran really stepped up. He actually made it clear in a speech on the Senate floor how important, and he did that in actually April 25, so I guess I was a little off my time frame, but basically how bad it could be for rural hospitals because of those changes, and really worked and worked and worked to help come up with language that would allow Kansas to move forward with what was approved by the 25 legislature. Since then, of course, there's been some guidance that's been a little bit challenging on making that move forward. And again, Senator Moran's team has been leading on that front, as well as Senator Marshall. Now, that's all on the provider tax related stuff. And I do want to say, even though I'm not going to speak to some of the other things, Senator Moran and Marshall also worked on the Rural Health Transformation Program, making sure it didn't require state matching funds, and then increasing the dollar amount available to that $50 billion for across the country. So lots of work done to help fund Kansas by our delegation. And I just can't thank them enough, because this could have been really, really hard on Kansas. And I think that we came out as good as we could expect in that case. Oh, Sheena, I'm sorry, I can't hear you. I apologize.
Don't apologize. I had myself on mute. Thank you so much. That's really helpful context to have. And I think given, so you said, okay, so Kansas kind of came out as good as it can. Well, so how specifically will the changes in HR1 impact the state's ability to finance its share of the Medicaid program through, let's just kind of focus on state directed payments moving forward.
Okay. Well, because the state doesn't finance our state-directed payment program, hospitals do by paying the tax to the state. What is going to happen is that the amount available is going to reduce by 10% over time, as we talked about through that 2038 time period. And so what that is going to mean is that that state-directed payment will be reduced starting in 2028, and hospitals will have to figure out how they're going to address that reduction in resources. Majority of our hospitals operate at a net negative, and so that's just adding to that negative. And I think, I know lots of people want to know, well, what does that mean for all of the rest of Medicaid? Quite honestly, for the rest of financing Medicaid, it's not going to have a significant impact, I don't believe, at this point. So again, everything could change because CMS changes the rules regularly. But as far as financing for dollars that are matched by the federal government, that's not going to be an issue because of the limitations that are set in place. The bigger issue is going to be financing options that are not matched by Medicaid, that are straight state general fund dollars, because that is going to be the only way to add back funding for hospitals in the Medicaid program, is if we don't get matched for it in order to stay below that cap with the state directed payment, because every dollar that is matched by Medicaid counts toward this expenditure limitation that is set for these state directed payments. And I think that's probably going to be the biggest challenge there.
Thank you so much. So thinking about options, you said you may have to go back to the legislature and understand how to address it. Are there specific policy level levers, partnerships, or alternative approaches that the state could consider?
Well, not, okay, so not necessarily from the state. Certainly our goal and what we will be working on is getting rid of this cap and this 10% down a year, just because it is going to be very difficult to maintain access to care. And so when we talk about the impact overall to Kansans, um, Medicaid population, non-Medicaid population, that's going to be the struggle, is access to care, because as hospitals have fewer resources to provide care, especially in our rural areas where sometimes the hospital's also running the clinic and your primary care, then they have to figure out how to keep their doors open and keep their primary services available, and figure out what to do with those other services. Some things that the state could do, again, non-match dollars. Locally, I think you'll see hospitals going back, if they don't already receive some local support to provide care, to ask for local funding to continue to fund and maintain those resources. And then, what the shifts will be as far as what's going to happen on changes in types of care, that will just all depend. Someone really smart once told me that uh, a lot of things are like a balloon, and I think healthcare is like a balloon, and that if you stress on one side, it pushes out on the other side. So we have a lot of partners out there in the safety net clinics and the CMHCs and the CCBHCs. We all work in the same area, and we're going to see those people pop out into those other areas if they're not coming to the hospital. Hopefully, they're going to a safety net clinic. If their services aren't available, hopefully, the services are available elsewhere in one of these other areas. But unfortunately, I do think people are going to start to have some real difficulty with access to care as hospitals have to scale back.
Hmm. Hmm. Okay. What are you hearing from Kansas hospitals, like regarding concerns, solutions as they prepare for these upcoming changes?
Well, right now, everybody is asking for, what are the numbers look like for us? What is
Yeah.
this change going to look like? And unfortunately, we can't, excuse me, excuse
Bless
me, we can't provide that because CMS hasn't told us what the formula is going to be for that reduction and what they're going to require for that. In addition, the approval for the state directed payment for calendar year 2026, which we're already in, is not yet approved by CMS either. And so that's going to set our baseline for any changes going forward, because that will be our cap on what can be spent. So that will be the number we can spend for 27. And then for 28, that's the number we'll have to calculate the 10% reduction against. And then again, we don't know what CMS's calculation is. So I think probably individually hospitals are sort of noodling through what they think that might look like. But until I think they really have some numbers to work with and see the long-term impact, I don't know that there are a lot of decisions being made at this point.
Thank you so much. Well, I'm going to go ahead and shift to my colleague Shelby. We've had a few questions that participants submitted in advance, and please also share any questions that you have in the Q&A feature in Zoom, and we can take a few questions this way for a few minutes. Hi, Shelby.
Absolutely. Thank you so much for having me. So, a few of the questions that we received within the registration really focused on the impact of these changes on specific populations. So, looking at how these changes may impact elderly adults as well as those with disabilities, that's an area that folks are really interested in learning more about.
Okay, so that is a great question, and I have been asked that before. I think initially was asked that question and thought, well, everybody's going to be fighting for the same money, which is always a struggle. I don't think that is much now. purely because, again, there aren't state dollars with the state directed payments. There's a limit on what can be spent. There's a limit on what can be matched by Medicaid. So we're bumping up against a cap that is being financed with non-state dollars. It's whether or not there's any opportunity to use state dollars but not have them matched by the Medicaid program that I think becomes the question. I think the bigger issue is not necessarily direct financing of programs. I think the bigger issue is probably access to care. Certainly for our populations that are in the more rural parts of the state, that the hospital, like I said, that the hospital also has said, okay, we're serving our community. So we're not only providing the 24/7 hospital care, perhaps we have a clinic, perhaps we, have an opportunity for a specialist to come in. All of those things have costs. And it really is going to be whether or not the hospital can continue to do their core mission and fund some of those services. So primary care may become more difficult. Some of those specialist clinics may become more difficult for Kansans to access, especially those that maybe don't drive, are in areas where they'd have to go a long way. And I think, as we look at it and as the association and our hospitals start having conversations as we go forward, this is going to be one of our big issues as well, because access to care is very important to us. That's why this program exists.
Absolutely. So one of the other questions we had kind of falls within that realm of rural health and specifically centers around students and residents training in rural areas. So with all of the changes, do you think we will see any impacts there in terms of students and residents being able to train for their careers in rural areas?
That's a hard one. There's a lot of work that goes into rural residencies just because of the volume and variety of experience that's necessary for that. So I think that is potential. I can't say absolutely yes or no, but again, choices are going to have to be made about where the investments go.
Thank you so much. I'll kick it back over to Sheena for a few more questions. And again, just a reminder, if you have any questions, please feel free to share those within the Q&A. Thank you, Sheena.
And I know there are four of you out there that were interested in what was going on with provider taxes. So come on.
Yes.
Let's do that work, the four of you.
More of you. Yes. Submit the questions. We did have a question from Amy in the Q&A. She says, does the 10% come off in 1 year or is it a phase down?
Oh, so it's a 10% phase down each year. So each year, so say we're at 250% in 27, it has to be 240% in 28 and 230% in 29. We're just not sure how CMS is going to calculate how that 10% reduction works. What we anticipate is that we'll have to do 4 different calculations on inpatient and outpatient for both the non-critical access rural emergency hospitals and for the critical access rural emergency hospitals, which is way more than those of you that are beyond the 4 want to know.
Yes, different types of hospitals will be impacted differently based on their rates that they're receiving for sure. Yeah, thank you so much. All right, we'll keep questions coming if you're interested. All right. So here, Brenda has a comment.
Yeah. I still don't understand provider taxes. So, okay. So maybe it's important to start with how much of the Medicare rate. So hospitals generally, Medicare pays 85-90% of what it costs to provide the care. Okay, so that's the cost. That's not what we charge. That's what it costs to staff the hospital, keep the building running, have the medical records, all of those things. So when you start looking at what Medicaid pays, at best, Medicaid pays about 50% of the Medicare rate. Okay. And so what provider taxes do is instead of the state providing the additional match, they allow the providers to pony up the match for the federal dollars. So I know I see in the chat there's this, what's our matching rate? 60/40. So the 40 cents that the state would provide to match the Medicaid, instead, that's provided through provider taxes and then matched by the federal dollars, which means if you put in 40 cents, you get back $1 theoretically. And so you've doubled your money and a little bit more, 150% actually. So it is a good bet theoretically for provider taxes. So what that means is then that increases the payments through the Medicaid program so that instead of being at 50% of the Medicare rate, we can be at 200% of the Medicare rate. Brenda, did that help? Okay, very good.
Very good. Yes, that's complicated stuff. Thank you so much for clarifying. Right. Well, we have some time for maybe one or two more questions. Um, so thinking about, you talked a little bit about it's not going to just impact people in the Medicaid program, it's going to impact other Kansans. So thinking about that, what does it mean for even privately insured patients and other Kansans who are receiving care across the state? How would it impact again?
Again, it's
Yeah,
still access. The
right.
services. So I feel like I should wear a t-shirt all the time that says no margin, no mission. I feel like I talk about money all the time, and that's not the most important thing we do. The most important thing hospitals do is take care of Kansans, period. Most important thing we do. But we all know that in order to do those things, you have to be able to finance those things. And so when we it's the reason we harp on dollars all the time is that, hey, if we don't have the money to hire the doctor, or OB is a good example. Lots of hospitals have given up their OB in the last 10 or 20 years. Well, to have an OB program in your hospital is very expensive. You have to have an anesthesiologist all the time. You have to have an OB. The liability on it is very high. And unless you are, having lots of babies born in your hospital, then those are programs that are net negatives for a hospital all the time. It's a service we want to provide, but hospitals more and more often are saying, we can't continue to do everything else we do and maintain this program. And so that impacts everybody. It doesn't matter if you're on Medicaid, private pay, uninsured. If you don't have access to services because your local providers can't fund the services, it's an access problem for everybody.
Hmm. Hmm. Makes sense. Thank you so much.
I do see a question,
Yeah.
behavioral health services also being a challenge.
Hmm.
Yes, I think potentially it could be a challenge. Behavioral health services are expensive, especially the inpatient services. I know we have lots of outpatient services. I know we have outpatient providers on this call. But yes, that does become challenging and potentially an access issue.
For sure. So thinking about how we can address some of these anticipated challenges, there's some time to prepare. Um, so what role can community partners, local governments, or regional collaborations play in helping mitigate some of these impacts? Since it is an access to care problem, it's a healthcare system. The system takes care of Kansans. So have you heard from, just thinking about, what people are talking about, hospitals and other organizations, how might they address this issue?
I think the big challenge often amongst healthcare providers is really being able to come together and have the conversation. This sounds so kumbaya, but it is true. is that, if you want to serve a community, everybody who provides care in that community needs to work together and go, okay, we know the emergency room isn't the right place for the person with the cold. They should go to the clinic or to the FQHC instead of coming to the emergency room. We'd rather that happen, as a hospital, because that's not the right place for them. And same thing, behavioral health. We know our hospitals coordinating with the CMHCs and the CCBHCs to make sure those patients are cared for in their communities. I think that is going to have to be strengthened as everybody figures out where they're going to land with these limitations and really what they're going to do with the increase in uncompensated care because of all of the other policy changes that we're talking about. Changing the look back period on Medicaid payments is also going to harm bottom lines for hospitals. Because, if you show up in the emergency room at the hospital under EMTALA, we're required to care for you. We have to stabilize you. And so that is a lot of the way patients wait till they're truly in bad shape. They end up at the emergency room. They end up in the hospital. We work through the process with them. For Medicaid, if they're Medicaid eligible, and there are whole groups of people who do nothing but deal with that portion of taking care of people. But if that look back period, you're cutting a month off of that. That does not bode well for bottom lines for hospitals. Rachel, presumptive eligibility. So yes, but I have questions about, so I will tell you, sorry, what I know, and I haven't looked at this in a while. The presumptive eligibility requirements are pretty stringent. The last time I looked at the requirements that the state of Kansas had implemented for the hospitals that can do presumptive eligibility, they have to be right most of the time. It's pretty high standard, which is okay. But yeah, how this all works together, I'm actually not really sure. And I don't know, Sheena, if it's something you've looked into or what we're going to see with additional regulations in that space.
Yeah, thank you for your question. That is something that we can look into a little bit more. And that's something that would be really important to understand, like what other types of eligibility processes might be impacted, or how would they be affected due, given the other changes that are happening. So yeah, we can take a look at that for sure. There's one more question I think we have time for in the Q&A. It's again kind of talking through like how will it affect private pay patients if a provider can get the 200% rate back. They bill private the same as Medicaid patients. So they're saying the middle class or self-employed are struggling to find affordable care coverage as well. So I think it goes back to that access to care a question. So how it'll affect private pay patients who are just paying without insurance. I think, yeah.
Okay. Wow, seems like an easy question. That is not. That is actually a pretty complicated question, especially at hospitals, because depending on where you are in the state of Kansas and what hospital you're accessing, all hospitals have and are required to have a charity care policy. And so those policies are definitely ones that you should always look into, especially if you are a person who is not insured, to figure out how you can cut down the cost on your bill, because those charity care policies are based on most of them on kind of a sliding scale. What is your income? You do have to do the paperwork. You do have to verify your income just like you would for anything else. But hospitals certainly do work with people who are uninsured, one through charity care and through payment plans. I don't know anybody.
Mhm.
I know through my doctor's office and my hospital, every time I get a bill, it's like, oh, also there's a button you can push. Do you want to go on a payment plan? Because it's far better to be receiving payments than have to put somebody in the bad debt bucket, which we never like to do, and to pursue them in order to get paid. That's not what we want to do. But I do think this this creates additional challenges. Again, as Sheena said, mostly it's an access issue. But I think your bigger question is this going to impact cost? And I think that it will. But I can't tell you how much. There's so many things that are unknowns because we don't have our hands on the numbers quite yet.
Thank you so much, Audrey. I know we could keep you on for a lot longer, but we only have an hour together today. We thank you so much for your expertise and insights this complicated issue. I will go ahead and turn it back over to my colleague Rebecca to close us out. Thanks so much again.
Thank you, Sheena. Thank you so much for facilitating today's session. And a big thank you to Audrey for joining us today and sharing your vast expertise and insights. We really appreciate it. And lastly, we do encourage you to visit our website, khi.org, to explore other events, resources, tools, briefs, publications, all kinds of information that you can use to help inform your work. And as always, thank you so much for joining us today for Bring It. We really appreciate your time, your questions, and your insights, and we hope to see you next Tuesday for our next session. Have a great afternoon.